some disclosure. So in this session, I'm going to highlight a couple of the interesting rectal cancer-related abstracts from ASCO of last year, as well as from ASCO GI of this year, and then talk about how the ongoing and future clinical trials are really going to change paradigms in how we practice. So this sour data has been presented about 100 times today, so we'll go through this quickly, but I think a background for a lot of the rationale for the addition of oxaliplatin to the fluoropyrimidines as radiation sensitizers really hinge on the fact that we still need more systemic or more effective systemic therapy up front because we're still seeing distant recurrences, which has been the most life-threatening for these patients. So that, as I mentioned, is a rationale for the NSABP R04 study, which looked at CAPE versus 5-FU and oxaliplatin versus not using oxaliplatin, and no difference in path CR rates, but a definite increase in grade 3-4 toxicity. Very similar results with the STAR trial and the ACCORD data. So I think no increase in path CR, but definitely increase in grade 3 toxicity. So in ASCO of last year, there were two abstracts, the PTAC6 data and the AIO04 data, which both looked at not only pre-op oxaliplatin with radiation therapy, but then also post-operative oxaliplatin as well. And here's the schema for the PTAC6 study. This one, as opposed to the other study, is using capecitabine with or without oxaliplatin, and then in adjuvant, both in the neoadjuvant as well as the adjuvant setting. And skipping ahead to disease-free survival, that was their primary endpoint, and was essentially no difference in disease-free survival with the addition of oxaliplatin, both before as well as after surgery. The relapse rate at 3 years, again, no difference. The AIO4 study just varied in the respect that they added 5-FU instead of, or used 5-FU instead of capecitabine, but again, using oxaliplatin both up front along with radiation therapy as well as in the adjuvant setting. This did show an increase in disease-free survival that was significant with the addition of oxaliplatin. And so when we look at the combination of all of these neoadjuvant studies, while the path CR rate is not increased in all of the studies, it was increased in one. This was an unplanned exploratory analysis. But I think in general what this did is confirm that, again, that oxaliplatin is not really a good radiation sensitizer when added, or doesn't add additional benefit to your fluoropyrimidine. Now this is during radiation therapy, so be careful not to confuse it with an induction chemotherapy, which we'll talk about a little bit later on. The other study, which has already been mentioned, is the smaller phase 2 ADORE study, which did randomize patients after standard pre-op chemoradiation therapy to receive either adjuvant FOLFOX or adjuvant 5-FU. And again, we did see a statistically significant difference in the disease-free survival for the overall intention to treat population. And as already pointed out, most of the benefit was in the stage 3 group, and in the stage 2 cancers, as we see with colon cancer, there's not a statistically significant difference. So if we look at the adjuvant oxaliplatin-based studies in colorectal cancer, we can see that all of the studies, with the exception of the PTAC6 study, do show a benefit, and it's for the most part the same degree of benefit across the studies. And the one question that I had would, why would PTAC6 be negative? And I think when you actually look into the details a little bit more, 38% of the patients did not receive adjuvant CAPOX versus 23% in the capecitabine arm. Only 53% versus 68% of eligible patients received all the intended therapy in the CAPOX arm. and 54 versus 35% received less than 90% of capecitabine in the capox versus the cape arms. So I think there is maybe some reasons why the PATAC-6 study was negative for disease-free survival. So again, I think these adjuvant studies or using oxaliplatin in the adjuvant setting for rectal cancer, I think they do confirm what a lot of us are already doing in standard practice, and that's adding, you're using FOLFOX or CAPOX in the adjuvant setting for stage 3 rectal cancers. So moving on to updates from Askogi this year. There's a couple of interesting studies that I thought were noteworthy. And one study was looking at the optimal timing of surgical resection after radiation therapy. And in this study, they looked at a large number of patients in a national cancer database. The rationale for this is that the timing of surgery is not thoroughly established after chemoradiation therapy, and there's some evidence that delaying surgery can lead to an increase in path-CR rates. And their goal was really to look at if there is an impact by delaying the surgery. They looked at over 6,800 patients, and these were patients with rectal cancer who underwent the standard preoperative chemoradiation therapy followed by surgical resection. Now, there's 87% of this patient population was Caucasian, 64% males. 57% underwent an LAR, 8.4% had a coloanal reanastomosis, and 28% had an APR. And what they did overall, there was about 6% of patients when they looked at it that actually received a path-CR rate, so not differing terribly from known literature. But they did note that the path-CR rate varied by the timing of the surgery. So less than 30 days from chemoradiation therapy, the path-CR rate was about 4%. But if they extended that to 31 to 75 days, it was up to 9.3%. And they didn't give the exact numbers of beyond 75 days, but stated that the rate declined. Now they looked at the mortality by timing, and they compared it to patients that had surgery within 60 days of chemoradiation therapy. So beyond 60 days, they found a 20% increased risk in mortality, and beyond 75 days, they found a 28% increased risk in mortality. There was also a higher rate of positive surgical margins after 60 days. However, they did note that those with surgical delays were older patients. They're Hispanic or African, which we know is a smaller percentage of the population studied. They were typically more likely to be uninsured and had a higher comorbidity index. So these may be patients that actually were going to do less well anyway. So I think this very large study does raise the possibility that there is an optimal timing after surgical resection, but I think other factors may have contributed somewhat to the mortality. I would like to have seen more details on local versus distant recurrence, but it does bring up an interesting question: how long do we wait for a path-CR? Which was a big topic in the next presentation that I'd like to discuss from Askogi this year was looking at a non-operative management approach. So Dr. Smith from Memorial Sloan Kettering presented their data on organ preservation in rectal cancer patients with a complete clinical response after neoadjuvant therapy. And the rationale for this is that we know that path-CRs occur in about 12 to 38% of patients, depending on which study you read. We know that a clinical complete response is associated with a path-CR rate, and the question is, can some patients be spared the total mesorectal excision? This would potentially avoid risks of postoperative mortality, as well as anorectal dysfunction, urinary and sexual dysfunction, and also the obvious benefit of not having to have an ostomy. There are, as has been discussed, precedents for this management approach before. In the Brazilian group has been probably has published the most data on this approach. And I think has presented provocative data over the years that a lot of us find intriguing, but don't know if we can trust 100%. But they looked at clinical complete response in patients that went to observation versus those that did not have a complete clinical response by their criteria, but then ended up having a path CR after surgery. And they did not, in their very small group, did not find a significant difference in terms of disease-free survival, and concluded that this is potentially a safe surgery or a safe management approach that spares patients from TME. This was also supported by evidence that was presented or published by Moss in 2011. And they also did a similar study looking at patients that had complete clinical response and went into a wait and see group versus those who did not appear to have complete clinical response, but then ended up having path CR at the time of surgery. And again, we're seeing similar survival results. So Dr. Smith at the Askogi presentation presented their data, which is a retrospective review ranging from 2006 to 2013, looking at 73 patients of over 400 patients that underwent neoadjuvant therapy for locally advanced rectal cancer. And 73% of them had a complete clinical response, and they compared this data to 72 patients who had a pathologic response noted at the time of surgery. The goal was really to assess the safety and the efficacy of this approach. From 2006 to 2011, they did what we consider standard of care with neoadjuvant chemoradiation therapy, surgery, and then adjuvant chemotherapy. From 2011 to 2013, the FOLFOX was actually moved up front, which again is not a standard currently, but is their approach. And so that there isn't really, or we have to take into account that there was two different approaches here. I think probably a very big point that we need to make is their definition of a complete clinical response. In that this was based on criteria on the digital rectal exam, as well as endoscopy, as well as imaging, and they did caveat most of the imaging was based on MRI findings. And I think also very importantly, they were careful to have good informed consent with their patients, explaining that there is 25% risk of local regrowth. And I think also extremely important point was their post-op surveillance. So doing endoscopies, digital rectal exams, and imaging studies quite frequently in their follow-up. On the patient demographics, I think the one thing to note is the clinical stage was a little bit more favorable in the non-operative management group. And so this is their data on organ preservation, and they did have about 26% local regrowths, with most of these were able to be salvaged with TME versus local excision. And this was sustained over a number of years. And also interesting to note was the timing of their recurrence, which most of the regrowths occurring in the first 12 to 13 months. Looking at their disease-free and overall survival, again, no statistically significant difference between the non-operative approach versus the operative approach for patients with path-CR. The one thing that I thought was a little concerning was in terms of distant metastases. Although these numbers are not statistically significant, it's a very, very small group, but numerically, when the one-year distance recurrence rate is 7% in the non-operative group versus 1.5% in the surgical group, and the 4-year distance recurrence rate of 17% versus 8%. So I think I'd like to see this data with a larger patient population. But again, I think the rectal preservation of 72% is very intriguing. So their conclusions were this study that there was 72% of durable clinical response at 4 years. A quarter had local regrowth, but most of these were able to be salvaged with surgery, and that the disease-free and overall survival were similar for patients. And just looking at other studies from high-volume centers, and again, we're seeing in terms of overall disease-free survivals, with the exception of this study here, very good and comparable to the operative arms. So there's a very nice review by Glyn Jones and Hughes from the British Journal of Surgery in 2012 that did a systematic review of this approach. And I think they highlighted some of the issues with this approach and why I applaud the Memorial Sloan Kettering investigators for their study. I think the definition of complete clinical response is inconsistent, so I think from in future studies, using the very strict criteria that have been proposed by the Memorial Group, I think will be very important. There's not always a good correlation between the complete clinical response and the path-CR, so that is one shortcoming of this approach. And then the timing, how long do we wait for patients to have a path-CR before going to surgery? There's also differences in surveillance. I think that is a critical piece here if you're going to use this approach for patients. And I think they noted some uncertainty in long-term outcomes with a larger patient population. So ongoing and future trials that I think have the opportunity to really impact our current paradigms of how we manage rectal cancer. I think they're moving forward, we're going to look at moving chemo up front and potentially using a non-operative management approach for those with complete clinical response. We're also looking at ways of utilizing neoadjuvant treatment period to assess the response to novel agents, and then potentially looking at patients where we can omit radiation, as has already been talked about. So in follow-up to the non-operative approach at Memorial, they are doing a very nice study. And I think I give them credit because there's no way that you could do a randomized study of non-operative management versus surgical management for patients with a clinical complete response. But in this study, they're looking at using induction chemo, followed by chemoradiation therapy, restaging, and then if there is a complete clinical response, consider non-operative management versus surgical management. The second arm is looking at using chemoradiation therapy first, followed by the systemic therapy, and then staging. One other concept that's been discussed on multiple occasions is looking at the total neoadjuvant therapy approach. Again, this is a way to look at novel agents and their effect. It's nice because you have a biopsy at the time of diagnosis, and then you also have the surgical specimen to evaluate the responses. And as already mentioned by Dr. Schrag, her intergroup study looking at whether radiation therapy can be omitted in a select group of patients. So when the Moss wait and see study was published, Joel Tepper actually had a nice editorial in JCO about the paper, and I think he highlights a potential stratification of patients and a future change in how we manage them. So breaking patients down, one first group looking at very low risk, very early stage tumors going to surgery alone. Those with moderate risk, so a T3 or no positive tumors that are high, considering neoadjuvant chemotherapy and surgery, and use radiation therapy only for patients that are still at high risk. For low-lying, moderate or low to moderate risk patients, looking at using chemoradiotherapy and chemotherapy and observation versus going to surgery if there's not been a complete clinical response. And then in high-risk tumors, looking at neoadjuvant chemoradiation therapy followed by surgery and adjuvant therapy versus moving the chemotherapy up front and along with chemoradiation therapy and surgery. So I think the ongoing clinical trials right now may have the opportunity to change the paradigms, and maybe this is something how we'll stratify and manage patients in the future. So in conclusion, based on results of these most recent studies, we have a consensus that fluoropyrimidine alone should be used as a radiation sensitizer. The benefit of oxaliplatin, I think, in the adjuvant study is confirmed in the ADORE study. There is provocative data to suggest that delaying surgery beyond 12 weeks after neoadjuvant therapy is detrimental to our patients. And a non-operative approach for a very select group of patients with very rigorous follow-up appears to be a feasible option for these patients. So, and I think that we should stay tuned to very big possible paradigm changes in rectal cancer. That's all I have. Thank you.